Good afternoon, and welcome to our webinar, Research Methods That Rock. My name is Karen LeBlanc, and I'm the Director of the Performance Audit Services section of the Louisiana Legislative Auditor's Office. I will be moderating our webinar today. First off, I'd like to thank the National Legislative Program Evaluation Society and the National Conference of State Legislatures for sponsoring this webinar. NLPES is the NCSL Staff Association for legislative staff involved in program evaluation or performance auditing. One of its key purposes is promoting professional development opportunities like this webinar for legislative staff. So we are pleased that we could bring this program to you today. This webinar is being recorded and will be archived on the NCSL website. Over the next 60 minutes, we encourage participation through our chat box. So feel free to type your questions and answer any questions in the chat box, which is in the lower left-hand of your screen. To build some comfort with the chat function and to also learn who is on the line today, I invite you to type in the state from which you are calling now. While you are doing that, I also want to mention the resources for this webinar. Above the presentation, you will see a couple of tabs. One is labeled Resources. Here you can find and download a PDF version of the PowerPoint as well as other handouts. Another tab is labeled Speaker, and this is where you can read short biographies for today's speaker. You can access these tabs at any time during the presentation. We will take your questions after the presentation has been given, but again, feel free to enter your questions in the chat box at any time. So our first speaker today is Matt Etzel and Daria Milikina from the Kansas Legislative Division of Post Audit. So let's welcome Matt and Daria.
Hi, thanks for having me today. My name is Matt Etzel. I'm a principal auditor with Legislative Post Audit in Kansas, and with me today is Daria Milikina, who is our office's audit methodologist. And we're going to be presenting today on our methodology and findings from an audit we did in 2018 that looked at the effect transitioning to a managed care model had on Kansas's Medicaid program. So I'm going to start by giving you some background on Medicaid in Kansas. I'm going to go over our audit objective and talk a little bit about the data that we needed to complete our audit objective, and then touch a little bit about some of the data reliability issues that we ran into. And then Daria is going to take over from there and go over our audit methodology and our audit findings. So to get going, a little bit of background on Medicaid in Kansas. Medicaid here covers medical and long-term care for low-income children and families, pregnant mothers, the elderly, and individuals with disabilities. Medicaid enrollment in Kansas in 2017, which would have been around the time of this audit, was at about 430,000 beneficiaries. And Medicaid costs in Kansas that year were about $3.5 billion. So in Kansas, we're pretty close. We're not quite at a 40-60 split between state and federal share of Medicaid costs. So about 1.5 out of that $3.5 billion came out of state funds for Kansas. So in 2000, sorry, I just learned that we just lost audio. Anybody fill me in on the last slide that we were on? Okay, Medicaid background. Sorry about that. So I'll just start back from the beginning of the slide. So in 2013, Kansas implemented CanCare, which really brought the state's entire Medicaid population under a managed care model for the first time. So prior to CanCare, low-income children and adults were already being served under a form of managed care, but individuals with disabilities and the elderly were still being served under a fee-for-service model. And that's important because individuals with disabilities and the elderly, even though they only make up about 25% of the state's Medicaid population, they accounted for about 75% of the state's Medicaid costs. So a relatively small but expensive population. So the idea was to take the state's entire Medicaid population, including individuals with disabilities and the elderly, and bring them all into a managed care model. And again, that's called CanCare. So that's what the state did. So by 2014, nearly 98% of Kansas's Medicaid population, including those with disabilities and the elderly, were served under the state's new managed care model. And one of the reasons for that, again, is to try to help to try to contain the state's rising Medicaid costs. And so we're talking about the main goals of CanCare. Again, one of them was to try to help contain the state's rising Medicaid costs. And one of the ways that CanCare sought to achieve this was to try to increase the use of preventative services. So under CanCare, beneficiaries are required to get certain preventative services throughout the year, like wellness exams, physicals, certain behavioral health services, with the idea being that over time, receiving those preventative services would help to improve beneficiaries' health outcomes and hopefully reduce the use of very expensive medical services like visits to the emergency room. So our audit objective then was to evaluate and determine, did CanCare achieve those goals? Did it contain the state's rising Medicaid costs? Did CanCare increase the use of preventative services for the beneficiaries? And did it help to improve beneficiaries' health outcomes? So to complete our audit objective, we needed a lot of data. So we spent actually several months working with our health department here in Kansas to collect around 200 million Medicaid claims records for every Kansas beneficiary from 2012 to 2016. So that gave us about a year of data from before CanCare went into effect and then a few years after CanCare went into effect to review. And that data included demographics information on the beneficiary, include Medicaid cost data, service utilization, and health outcomes information. And we use that information to try to do two different levels of analysis. The first was just kind of a basic trend analysis. So we just wanted to see how had claims costs, service utilization, and health outcomes, how had those changed from before CanCare to after CanCare? But we realized pretty early on that there are a number of variables that can affect claims costs, service utilization, and health outcome during that time, CanCare being just one of them. And so we knew that we needed to develop a regression analysis in order to try to isolate as much as we could CanCare's specific effects on cost utilization and outcomes separate from those other variables. And that's what Dasha will get into more in just a minute. But so that was our plan, was to do those two levels of analysis on those three different variables. But we ran into some pretty significant data reliability issues. So fortunately, the cost data, the claims cost data was reliable for our audit. So we were able to look at, what was CanCare's effect? What was the effect of transitioning to a managed care environment? What was its effect on Medicaid costs in Kansas? But the service utilization data was only partially reliable. So we wanted to look at CanCare's effect on 12 different services, how beneficiaries were using those 12 different services. And unfortunately, due to those issues, we were only able to look at 6 of those 12 services. And then the health outcomes data that we wanted to look at was it was entirely unreliable. So unfortunately, we weren't able to conclude on CanCare's effect on health outcomes at all as part of this audit. But with that, I'll turn it over to Daria, who will talk about our audit methodology and findings.
Thank you, Matt. And hi, everyone. I'm going to talk about regression methodology that's for our analysis. Also, we'll share some results and the lessons that we learned from our audit. As Matt mentioned, we had several questions that we need to answer. First, we needed what effect of CanCare had on cost of services. To do that, we took our large number of individual claims. We wanted to smooth the discrepancies over time. So we combined for every person claims into quarterly total for cost. As a result, we had data on the cost by person for 4 years and was 1 year before Medicaid and 3 years after, despite what it says on the slide. We combined that data to the enrollment data that we had on a separate file, and then we did our regression analysis. I'm not going to walk you through equations for regression analysis. If it's your kind of fun, you're welcome to email me, and I'll give you more details, but I'll explain on a high level what we did. The dependence variable for cost was the log transformation of the total quarterly cost, which is a common technique when you deal with things like that. We controlled for demographics, population group, and our variable of interest was a dummy variable that indicated the period after CanCare was in effect. Also our data set was in a set of panel data, which means that every individual was followed over time. And as a result, our model of choice for the cost of service was ordinarily squares with fixed effects. The fixed effects part means that besides the things that we explicitly control for, we also were able to control for unobserved characteristics of the person that is stable over time, but could have an effect on the health outcome. It wasn't the type of model that we could have used there, but we didn't have control group to be able to use the best model that we could have used here, difference in difference. And Matt mentioned some population groups were under managed care before CanCare started, but when we talked to the agency and other experts, we realized that it was completely different type of care. So we couldn't treat them as a control group, and we just did kind of the before-after analysis. For population, it was very similar, except our dependence variable now, instead of cost, was the total quarterly count of services in the claims. The claim, they have the code, service code of what was performed, and those codes, they have just common classification. So we were able to wrap them up into categories, such as inpatient care or mental health care, and then we had data of these categories by person, again, for 4 years. The model was had very similar setup, except now dependence variable anymore. So instead we used less, we used Poisson. And again, we didn't have control groups, so we couldn't use difference in differences. For the health outcomes, Matt already mentioned data was unreliable. However, I want to share with you one piece of analysis that we did that didn't get into report. It was a small piece, so we didn't feel like it was helping us to answer a question in full. However, it was a good exercise that we learned from. One of the goals of CanCare is to improve pregnancy outcomes by utilizing preventive care. And to do that analysis, we didn't use claim data. At this point, I don't remember how we came up with it. Probably it was in some of the research papers that pointed out to us in that direction, but we went to vital statistics to get data. And vital statistics has very good data set that they collect to issue birth certificates. You fill out the forms when you apply for birth certificates, and there is a whole bunch of questions. And it includes everyone. It includes all population, whoever was born in Kansas during certain time periods. It has a question that indicates if mom had Medicaid. And there are also known birth outcomes, such as weight of the baby, so you can see if the baby was underweight or normal weight, and if the baby was born preterm. It also has really good demographics data for mom and dad. And because it included all population groups, we were able to have a control group. And in this case, we were able to do difference in difference, which means that when you have, you compare a control and treatment group, and you assume that two groups have some sort of trend that they follow similarly just because they're similar. But the treatment group is affected by the treatment, the change in policy, in this case, CanCare. And when you compare it to groups using regressions, you can separate that treatment effect, and you can say that that was because of the policy. So to me, we were able to do that. And to me, that was the least problematic data set and the least problematic analysis that we did for our audit. As a result, we found that birth outcomes changed very little or not at all after CanCare. And I'm also going to share with you the findings that actually got into the report. As you can see on the slide, the trend analysis for the costs show that Medicaid costs remain stable over time, including after CanCare when we adjust for inflation. When we did regression analysis, we saw that CanCare was not responsible for keeping those costs stable. It is likely that other factors such as demographic composition of the population that probably changed over time was responsible to keep the cost stable. So the results of regression show that after controlling for all the factors that we controlled for, we found a 20% increase per person on average of the cost after CanCare implementation. And for the utilization of services, we saw that 3 services that were preventive care increased their utilization, which was expected. And also, we saw that inpatient care did not have a huge change. That indicated that even though the preventive services were used and increased the usage of it, it didn't correspond into less hospitalizations. I want to point out that we didn't have a lot of years after CanCare, so it is possible that we didn't see the effect just because not enough time had passed. And lastly, I want to share some lessons that we learned from our audit. First of all, not exactly something we learned. We expected it and we knew it already. The Medicaid data in Kansas is, what's the word I'm looking for? Not in good shape. But what we learned is when you do research and you use regression analysis, you have these hoops that you need to jump through to show that your model is perfect and that the results that you found are exactly what you were looking for. For that, you need to have really good quality of data, and also often the data availability and the quality indicates, well, kind of shapes your research question. When you do the audit, you don't have this freedom, and also you don't have good data, but that doesn't mean that you cannot do regression analysis. You still can evaluate the effects. You have to spend just much more time thinking about limitations about of your models and what you could be missing, and make sure that the results you're seeing do make sense. Also, speaking of research papers on similar topics are a good source of information. You have all these challenges that you encounter during your work, and they probably had same challenges, and they can help you to see what you can do to fix it, or potential approaches to do your analysis. And when I say similar topics, it doesn't mean like exact your topic. In our case, it's very rare that researchers get access to individual Medicaid claims data. So you could look for all insurance claims data or health outcomes in different countries, and that you broaden, by that you broaden the pool of what is available in previous research. Another good thing that we learned is that Vital Statistics has really good data. It is in good shape. It is used. They're used to people requesting the data. We've got data from Vital Statistics in 3 days, We've got Medicaid data from the agency, I think, after maybe 4 months, maybe more. Another thing, when you do regression analysis for the audit, it's very hard to explain regression results and analysis in the report, and I don't have a good solution for that. If you do, please let us know. The goal is to make it as clear as possible so people understand it and don't dismiss your results just because it's too complicated what you did. And speaking similar to that, the easy critique that you can have when you do this kind of policy analysis, the effect of the policy, is that a lot of other policy changes happen at the same time. And what you see can be not the result of the, in our case, can't care, but can be a result of any that other thing that had changed. That's a valid critique. It could be happening. So you need to keep this in mind and address directly in the report when you describe your limitations of the analysis, or if you have a lot of time, you can also dig into these changes and see were they big enough to be able to affect the results that you're seeing. And with that, I conclude our description of our journey with this audit. Thank you.
All right, great. Thank y'all for that. Our next speaker today is Edward Seiler, and he is from the Louisiana Legislative Auditor's Office. So, Ed, I'm going to hand it over to you.
All right, well, thank you, Karen. My name is Ed Seiler. I'm an economist with the Louisiana Legislative Auditor's Office, and I'm really excited to be presenting to you about our performance audit on local government bond issuance costs. So just to give you a brief overview of the project, there's three things we'll talk about today. First is our methodology for analyzing cost of issuance for local government bond issuances. The second was one of the results from our report, which was that better tracking of issuance costs could help the Bond Commission and local governments to identify potentially excessive costs. And the second result from our report, which was that competitive bidding could help local governments to save potentially $1.2 million a year in cost of issuance. So with that, I'll go ahead and jump in. Just for some background, it might be worth noting what are bond issuance costs. This is different from the principal that you're repaying on the bond or the interest that you're paying. These are the costs that you have to pay to professionals and other companies who assist with the transaction. So it's going to be the bond counsel, financial advisor, the underwriter or bank. And so all of these groups receive fees up front that can be very costly in some cases. And in Louisiana, we have a somewhat unique process in that this actually goes back to Huey P. Long in 1935. They passed a law. They had a special session. The Times-Picayune, actually the newspaper in New Orleans, said that they were dictating these laws, or that Huey Long was dictating these laws. And one of them was that all local governments, if they were going to borrow money, had to receive approval from the a state board. And so that process has been reformed over the years. It's more multilateral now, and there are more members on the Bond Commission that approves these, but still the basic premise is still there that if you want to borrow money as a local government, you have to get state approval. And one of the first steps for that is that you have to have estimated fees. You have to estimate what those costs are going to be and submit it to the state. And so the Bond Commission looks at that, and then after the fact, you also have to report the actual costs to the Bond Commission so they can make sure you didn't exceed the initial estimates, and if there's increases, you have to justify it. So this information, of course, unfortunately, is not all in the most convenient format. The estimated costs were available in a digital format for some years, but we really wanted to look at the actual costs because this was going to be what people were actually paying, and sometimes the actuals come in less than estimated. So we created a data collection instrument to digitize this information, which was just on scanned paper forms, And one of the things that really helped with this was we used Microsoft Access. I mean, this form has probably over 100 fields on it. And so that would drive you crazy if you were in Excel trying to scroll horizontally like that. So we created an Access form that was structured kind of the same way as the forms, and that made it a lot quicker to input the information, and was probably very good for our sanity as well. And so then we wanted to know about competitive bidding because there are best practices that recommend that. And so we created a survey and surveyed local governments to see if they were using competitive bidding. And so then we looked at all this information to see if there were, if there were any instances of outlier fees that were really high, and how much variation there was between governments that did or did not use competitive bidding. So one of the first results that we had from this is that there could be benefits to tracking issuance costs, and specifically tracking the actual issuance costs. And so by doing this exercise, we were able to very quickly group bonds together. So there were groups that were very similar groups of bonds. They had the same type of issuer, same approximate survey amounts, same approximate principal amounts, and similar pledge of repayment. And so just to kind of give you an example of what this looks like, we looked at, this would be an example of the bar graph on the right, shows you several different bond issuances for, like I said, 6 different cities. And you can see the red region on the right side of the 2 bars at the top there. That's kind of the amount that's above average. The gray bar at the bottom is the average amount. And so there were some instances where you had local governments that were paying more than what other local governments were paying for basically the same service. And so that amount adds up over the entirety of the state, and over a 4.5-year period, it added up to about $6.7 million. And we call these, potentially excessive costs. It's not to say that they are. I mean, it may be that if you look into it, it may be, for example, that City A was, took a long time to finish something, and it required a whole lot of extra legal work, or they had other problems. But it would help the Bond Commission in prioritizing what to look at. And this would help local governments as well, because if you're City A, you might not realize that, City B, City D, E, et cetera, the other cities are getting a better rate. So this would help potentially both of them, and it'd make it possible to do this in a more rigorous way. The way that the Bond Commission had been looking at fees, doing comparisons, was that they would go through and try to find a similar issuance. And as you can see, there are usually multiple similar issuances, and so it might be better to be able to just do an Excel filter and pull up a whole list of them. So we think that would be one useful recommendation, and the Bond Commission agreed with this idea. The other area that we looked at was competitive selection. The Government Finance Officers Association specifically recommends competitive selection for bond counsel and financial advisors, which are 2 of the main professionals that assist with a bond issuance transaction. And our own local government services section, which advises local governments, recommended competitive selection for services contracts just across the board. And so we did a survey, and we found that 38% of local governments were using competitive bidding. And we found this. We did 2 waves. First, we did a Survey Monkey survey, and we looked at who responded to that, and then we tried to ensure that we had responses that were relatively balanced against the different types of governments. And so what we did to try to increase the response rate, similar to, I guess, what they do for the census, we went and called some local governments and just tried to be very persistent. And that's how we tried to make the sample as representative as possible. In addition to that, we did just as a kind of heuristic approach, we looked at all the issuances from January 2013 through June 2017, and we looked at which professionals they used, and we found that 74% of the issuers that had more than one issuance were using the same professionals every time. And so that, doesn't suggest that there's a whole lot of switching that's going on. And so we already had really strong recommendations saying this is something that reduces costs. So we wanted to know, we just did a very simple regression to try to see what was the difference in costs, and we found that based on that, cost of issuance could decrease by about $1.2 million annually, and that's after controlling for things like the principal amount, the issuer type, and the pledge type, different attributes that we would know about each issuance. And so that's just the cost side, of course, and those savings would be either it would be a savings to the taxpayers or sewer customers or whatever in that parish. It would also potentially be it would free up funds that could be used to spend on other capital improvements. So it would either way it would have a public benefit. What's harder to quantify, but still just as realistic as a potential benefit from this, is competition on quality of services. Particularly for financial advisors, that industry has seen a lot of consolidation lately, or some regulatory upheaval because there's more regulations on it now, and there are some people who probably provided a very kind of basic level of service before, and it's probably going to be a lot harder for them to meet these more stringent requirements that are part of the Dodd-Frank Act. And so we think that some financial advisors told us they offer higher quality data subscriptions. We also talked to some bond counsel attorneys, and one of them said, that if banks find out that a different bond counsel attorney, a particular one is going to be on a deal, they say, oh no, we have to have our own underwriters counsel because we think he's going to mess it up. And so all these kinds of things, that might not be something you would know and you wonder, why do I always have to pay for a separate underwriter counsel? These kind of things might be things that you could learn by having greater competition. And we did note in the report that these bond counsel attorneys, they have oftentimes decades of experience, and they are, sometimes they are the institutional knowledge. Mayors come and go, and the town clerks or what have you with them, boards of aldermen, what have you. But the bond counsel attorneys have been there for a long time, and they might even know a lot more about that particular local government than the actual government officials. And so that's something certainly that people should be aware of. But there's two things in response to that. First of all, that if you have new people that you bring in, new professionals, they might know something new that the old ones didn't know. And the other issue is that you can continue working with the same people, but if it's our local government services section says that competition creates a competitive atmosphere, and it would be an environment in which the professionals know that they really need to try to keep up with what's the best practice that's out there, in terms of bond issuance. One of the questions that we have is what percentage of that is that 1.3 million of total, or 1.2 million of total issuance. And I'll say over each period, the bond issuance costs were, over each year, it was about anywhere from 31.6 million to 40.3 million. So, maybe not large in as a percentage, but could be large when looked at in aggregate. So as a result, we had some recommendations for the Bond Commission. We already are recommending through our local government services section that locals use competition and use competitive selection. We did have some recommendations maybe that the Bond Commission could consider to encourage that. One of them would be by making available lists of professionals who are qualified. In many cases there are external sources who have lists of bond counsel. They talk about, I think it's called the Red Book is one of them. There's also the, for municipal advisors or financial advisors, they have to be licensed. And, obviously banks have to be, chartered, et cetera. So they could make that information available, and The other thing would be template documents, because it's very important if you're doing a formal bidding process, to say what you're asking for, and then there are public bid laws and different things. So, but a lot of local governments have really very similar basic needs, and so if there's something that they could take and adjust, or maybe have their general counsel for their local government look at it, that might be a way to kind of grease the wheels on that process and help them get started with it. So in conclusion, just discussed, bond issuance fees. What are they? How did we analyze them? And we had 2 recommendations. One of them would be better tracking to help identify those potentially excessive fees and costs of issuance. That would be something that could be helpful to bond commission analysts and to local government officials. And we also recommended competitive bidding as a way to save on costs of issuance. I see one question about whether these whether competitive bidding would lead to increased costs for local government salaries. That's a good question. In terms of how much time it would take, I don't know, and it might be something that they could absorb, just as part of their ordinary process. But that would be something each individual local government would presumably have to look at in evaluating that decision. So with that, if there's any more questions, I think we'll have a question period at the end, but I appreciate all the questions. And with that, I will hand it back to Karen. Thank you very much for listening.
All right, Ed, thank you. So our final speakers are Danielle Childress and Jeff Lenardi from the Virginia Legislative Audit and Review Commission.
Yes, hi you guys. As Karen mentioned, my name is Danielle Childress, and I have my colleague Jeff Lenardi here with me as well.
Hi everybody, happy to be riding shotgun with Danielle on this one.
The work we'll be talking about today was conducted as part of a 2018 review of spending on inmate health care. As a bit of background before we jump in, correctional systems in the U.S. are constitutionally required to provide inmates with reasonably adequate health care. It's a protection under the 8th Amendment against cruel and unusual punishment. However, in the years prior to the study, the cost of providing this care in Virginia was increasing significantly. From fiscal year 2007 to 17, the Department of Corrections' overall budget increased about 6% when adjusted for inflation. In comparison, the medical portion of their budget grew about 40%. So our commission was concerned by these increases and wanted to understand what factors were driving costs and what, if anything, the state could do to control those costs. So JLARC was asked to conduct this review. So the methodologies we're going to talk about today were used to answer 2 key questions posed by our study mandate. The first of which is, are DOC inmate healthcare costs reasonable compared to other populations? Our commission asked specifically for us to compare inmate healthcare costs to healthcare costs of other similar patient populations and to inmates in other states. But before comparing inmate healthcare costs to those in other health systems, it's important to know that inmates in Virginia and nationally have higher healthcare needs than the non-incarcerated population. Inmates are more likely to have chronic health conditions. They're more likely to have a history of mental illness or substance abuse. Additionally, because of the stress of incarceration, people age faster in prison than they would have otherwise. So comparing DOC health costs to, say, state employee insurance premiums was not going to be particularly helpful. Knowing this, we turned to experts for recommendations on what would be reasonable comparators, and they suggested our best options would be other states' prison populations, the inmate population in Virginia's jails, and then the Medicaid population. Because of socioeconomic factors and the eligibility requirements for Medicaid, that patient population also has higher healthcare needs than the general public. So we compared DOC's healthcare costs to those in other state prison systems, but couldn't do a very sophisticated analysis of those costs, and also didn't have a lot of confidence in even average per inmate costs. And that's because the cost categories and kind of what counts as inmate healthcare can differ substantially from state to state. We also collected some preliminary data on healthcare costs in Virginia's jails, but found that jails typically provide a different lower level of healthcare than prisons do. And that's not to say the quality of care in jails is lower, it's just that jails provide fewer services than prisons because inmates are generally there for a shorter length of time. So that left us with the Medicaid population, which we thought would be a good comparator if we could control for some significant demographic and health differences between the two populations. Essentially, the question we wanted to answer was, what would Medicaid's per person healthcare costs be if the Medicaid population looked like the inmate population? So to answer that, we needed to control for factors that strongly correlate with healthcare spending and that DOC and Medicaid populations differed substantially on. We found that those key factors were age, gender, disability status, and mental illness or mental health status. At the time of this study, Virginia had not yet expanded Medicaid, so the Medicaid population was made up of different subsets of folks in various eligibility categories, and those categories included, among other things, low-income children and their caretaking adults, people with disabilities, and people with severe mental illness. So there were obviously no young children in our DOC population, and there were also drastically different rates of people with physical disabilities and serious mental illness in the DOC population and in the Medicaid population. So we were going to need to control for those differences. So to account for that, what we needed was data. Luckily, we had nearly all the data we could ever want on DOC's inmates' demographics, health status, and costs. The department maintains health data that includes a work code, which is used to determine an inmate's physical ability or inability to work. So it serves as a sort of proxy for physical disablement. DOC also has a mental health code, which the department uses to understand what mental health services each inmate needs within a facility. We also had very detailed per person costs for inmates as well. On the Medicaid side, we didn't have person level data in the same way that we did for inmates, but our Department of Medical Assistance Services, or DMAS, provided some enrollment data and total health expenditures by age, gender, and those different eligibility categories we talked about. So we could see the total enrollment and total expenditure for, say, men aged 35 to 39 who were eligible for Medicaid because they had a physical disability. From this data, we were able to create 60 unique categories of Medicaid recipients by gender, age, disability status, and calculate an average per person cost. Once we had average costs for each unique group of Medicaid recipients, we calculated a weighted average based on those on each group's representation in the DOC inmate population. Using those work codes and mental health codes in the DOC data, we are able to estimate the portion of inmates with a physical disability or severe mental illness. If DOC didn't have that detailed health data, the analysis would not have been possible. So it looks like we may have missed a slide somewhere. There was a table that I can talk through a little bit that showed men aged 35 to 39 with no disability and no severe mental health illness made up about 14% of DOC's inmate population, while men of the same age bracket and physical disability with a physical disability or serious mental illness made up a much smaller proportion of the DOC population. So a weighted averaged let us make up a sort of hypothetical patient population that had Medicaid costs but DOC characteristics. So once we calculated that weighted average, we could then compare the hypothetical patient population costs to the actual inmate population costs. We had the true DOC healthcare spending data, right? So we could look at this hypothetical group versus the real group in the real world. And when we did that, we found that per person spending was actually slightly higher for Medicaid recipients than for DOC inmates. And in conjunction with some other evidence showing that DOC's healthcare spending was near the median of spending in other states, this result led to the team to conclude that DOC spending was not wildly out of line with other populations. And this was really helpful in providing context to the legislature that we, unfortunately, probably weren't going to find ways in which the system could find major cost savings opportunities. It was helpful, frankly, in limiting their expectations in that way. So next, we'll switch gears a little bit and attempt to answer a second key question in our study mandate, which was, are Virginia's inmate healthcare contractors able to provide care at a lower cost than the state would otherwise? And I'll provide some background there. On a basic, pretty simple level, states have two options when deciding how to provide care to inmates. They can either provide that care directly through state-employed nurses and doctors, or they can contract out to private companies that specialize in prison healthcare. It's a bit of a spectrum, but most states fall closer to one end or the other, or they use both approaches but delineate by service type. A state, for example, may provide most medical care at their facilities with state-employed physicians, but hire a contractor to provide the mental health services across all facilities. That's the typical approach in most states, except for Virginia. Virginia is unique in that we are the only state that houses about half of our inmates in facilities where all the healthcare providers are state employees, and about half of inmates are in facilities that are fully contracted care. DOC's argument for this approach is that the department can affordably provide care to relatively healthy inmates, but facilities that house sicker inmates or inmates who need more specialized care benefit from the flexibility of contractors. The issue is that this theory had never really been tested because the patient populations are so different. DOC intentionally was contracting using contractors in facilities with sicker patients, so you couldn't directly compare the costs. So the question we as researchers wanted to answer was, would contract and non-contract facility spending be similar if the patient populations were similar? So again, we needed to control for patient differences. I hope you're sensing a theme here. Luckily, as I mentioned earlier, we had a ton of data from DOC to do this. For all inmates, regardless of whether they were in a contract or non-contract facility, we had demographic data, we had transfer data, which told us which inmates were housed in which facilities and when. We also had health data that included the work code and mental health code I talked about earlier, as well as over 50 different dummy variables for different diseases and chronic conditions. We also had claims level data for all off-site care and prescription drugs for all inmates in all facilities. We didn't have detailed data on the care provided in the prisons, but for services that were provided outside of the facility in a hospital or a doctor's office, and for prescription drugs, we had all the claims data, and that data spanned from 2015 to 2017. So from those data sets, we were able to put them together and create this massive analysis file that had one record per inmate, per fiscal year, per facility, and summed that healthcare spending up for each. So if an inmate stayed in the same prison all year, they had one record with all their off-site care and prescription drug costs for the year. However, if an inmate transferred during the year, there could be 2 or more rows for an inmate in the same fiscal year. The file looked something like this fake data if it then had another several dozen health variables off to the side of it. Note that the file includes a dummy variable for if the inmate was a user, is the term we used, or recipient of off-site care or prescription drugs. And once we had this big analysis file, the team then used it to conduct 4 regression models that predicted prescription drug utilization, so whether that dummy variable was a 1 or a 0, prescription drug spending, off-site care utilization, and off-site care spending. And those predictions were based on the inmate's age, gender, and health status as documented by DOC and all that healthcare data, or all that health data we had. That predicted person-level utilization and spending, which was then aggregated to the facility level. So we could say we would predict spending at Greensville to be X dollars based on their patient population. At that point, each facility's predicted utilization and spending could be compared to their actual utilization and spending, right? The team could evaluate whether facilities were spending more or less than could be expected given their specific set of patients. Now, I will say that a facility that spent more than predicted was not necessarily viewed as inefficient, or a facility that spent less than predicted was not immediately seen as more efficient. We were dealing with relatively small sample sizes. There are about 30,000 inmates across 25 facilities, but we felt good enough in the analysis that if there were systematic differences between how contract and non-contract facilities fared, we felt that that would be an indicator of one or the other realizing some cost savings. So after we did that, we sliced and diced the regression results a ton of different ways. We looked at each of the 4 models separately. We combined prescription drug utilization and spending into one model and off-site care spending and utilization into another. We combined all 4 models into one. We looked at the 3 fiscal years separately. We looked at the 3 fiscal years all together, and the results largely stayed the same. JLARC staff found no evidence that contract facilities were spending systematically more or less on off-site and prescription drug services than non-contract facilities. This finding, while on its own is a little underwhelming, it was the backbone for a lot of the findings in our report. We found that while contractors were not losing money for the state, they also likely weren't saving the state any money either. Additionally, other analyses conducted throughout the study found that contractors were not able to staff facilities more effectively, which was another reason DOC had given for using contracts, and there were greater quality concerns at the contract facilities. So all those findings taken together brought into question for us whether the state was really benefiting from the use of contractors, and we were able to craft a pretty compelling argument to that end in our report. So when thinking about advice for other agencies like ours that are considering doing work like this, I would say 2 things, and both are more geared toward the second methodology we discussed today, the regressions. First, frankly, think about whether you really need to do this analysis. We were working with very sensitive person level health data. We could see every prescription drug and healthcare claim for every inmate that had been in DOC custody over several years. The data security risk alone may not be worth it, and these were also massive files. So the regression analysis took months of data cleaning and manipulation to even create the analysis file. Before we could run the analysis to answer the questions we really wanted to get at, we ran a ton of exploratory analyses to identify which of the health variables were predictive of utilization and spending, which had some potential coding issues. Inmates also transfer between facilities super regularly, and their health variables can be updated at any time. So figuring out how to cut those variables in a way that could be simplified, but still be accurate took a lot of time and a lot of trial and error. The ultimate analysis file we used was not the first or second or third attempt. It took a really long time to build. Also, as I mentioned, we didn't find an exciting headline-grabbing difference between contract and non-contract facilities. We needed to do this analysis to really understand whether contractors were saving the state money, particularly given all the other concerns we had with contractors. And because of the drastic population differences, this seemed like the best approach for us to do that, but you may not need to do something like this to address your study mandate. Second, I would say if you're going to tackle an analysis like this, build in the time to think about how to explain it to folks. The folks from Kansas mentioned this too. Our staff methodologist and I had a hard time trying to figure out how to explain the methodology to other JLARC staff, let alone the legislators on our commission. Our members do not care about the cool regression models that we ran to get the final answer as much as we wish they did. Ultimately, because of the technical nature of the analysis and the fact that there was not a systematic difference, the discussion of this analysis ended up being about 1 page of our 50-page final report. There were several long appendices to back it up, but it wasn't a large part of our final written product. And that wasn't because we didn't find the analysis useful or we didn't trust the results, but the finding was ultimately much more important to highlight than how we got there, and explaining how we got there was particularly difficult in this case. So with that, I'll say thank you for taking the time to listen to our presentations today, and I will go ahead and turn it back over to Karen to moderate our Q&A session.
All right, great. Thanks to all of our panelists really for discussing your award-winning methodologies with us. So now we're going to move to our question and answer period, and if you haven't done so already, please type your questions in the chat box at the lower left, and we have about 5 minutes that we can ask the panelists some of the questions. So let's start with Kansas. One of the questions that came in, I guess for Daria, did you have any problems with the consistency of coding? And if you did, how did you deal with it?
Well, I mean, of course, it's the usual problems of the manually entered data. I'd say On the medical side of data, it was a little bit cleaner because once providers or MCOs submitted to the agency, they run it through several tests to make sure that coding makes sense, that they submitted correct amount of hours and all these things. One example I want to mention was that one of the organizations, they were coding total cost that included the late payment fee, which they shouldn't be doing. And two other managed care organizations didn't do that. When we learned that, we created kind of a hypothetical data set, or from our data set, we had created a hypothetical example. We massaged the data a little bit. It is a small amount. So we pretended what would happen to regression analysis if we removed that amount. And we saw that if we hypothetically remove it and we rerun regressions, there was not really a huge effect on the results. So we decided not to go and try to do the actual cleaning. We did mention that they were including the late fees in the report for the oversight purposes.
Okay. So, Ed, I think you had a couple of questions, but I believe you answered them in your presentation. So we have time probably for only one more question. So to Virginia, could more limited access to healthcare services for inmates affected your results?
Yeah, that's a good question. I was actually kind of pondering that after I saw it pop up. We did per person inmate costs. So if it was an issue of fewer people being able to access services, I think that takes care of some of that. Also, while we didn't have claims data on, we didn't have like detailed level claims data on the care that was provided in facilities, we did still have the total spending on that care. So the cost of providing on-site care was still included in there as well. But that's frankly a good question. And I don't know if Jeff has anything to add there, but that is something to think about, certainly.
Yeah, I would add something, Jeremy. I think it's a really good question, and we did wrestle with that, and frankly some other areas of the study, but then sort of brought it to bear on this. When we thought about sort of access to services, I think there is a natural inclination to think that inmates would have less access, and to the extent that they don't have freedom of movement, they can't decide to go to the emergency room on their own. They can't decide to call a specialist and schedule their own appointment. That does have sort of it put some control around how they access their care. But when we look at our Medicaid population, at least in Virginia, we have wide swaths of rural areas where providers aren't necessarily available and transportation is a big obstacle. Neither of those two obstacles is an issue for Virginia's prison population, in that primary care is provided in the prisons by doctors and nurses who are physically located there, and when specialist care or hospital care is necessary, obviously the state's required to provide that transportation. So in looking at it sort of from a macro standpoint, and I'm also talking to the DOC folks and the Medicaid folks and the other experts who recommended the Medicaid population, we felt pretty confident that it would come out in the wash, but it is definitely something to consider.
Okay, I think that's about all the questions, the time for questions we can answer. So if we didn't get to your question, I urge you to reach out to the panelists individually through email. So again, I want to thank all of our panelists. Thanks to NLPES for setting up this webinar, and thanks to all of you out there for joining us today. This webinar, again, has been recorded, and you can access it on the NCSL website in a couple of weeks. The webinar is now concluded. Everyone, please stay safe out there. Thank you.